From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to our listeners around the world. You're listening to JAMA Author Interviews. Thanks for joining us. I'm your host, JAMA Associate Editor, Dr. Joynt Maddox. Today, I'll be discussing tracking U.S. healthcare spending by health condition and county with Dr. Joseph Dieleman, Associate Professor of Health Metric Sciences at the Institute for Health Metrics and Evaluation at the University of Washington. We'll also be talking about a companion paper that takes a deeper dive entitled Drivers of Variation in Healthcare Spending Across U.S. Counties, published concurrently on JAMA Health Forum. Thanks for joining me today, Dr. Dieleman.
Thank you.
So let's get started. This is a big, complicated project. It's a ton of data, and I want to get to that in a moment, but start with something pretty simple. So why did you set out to do this project right now?
Great. Thanks for asking. That's kind of an interesting question. The landscape of measuring health outcomes has gotten more granular and more granular. So if you think about mortality estimates, there are estimates for the mortality or life expectancy by race and ethnicity, by education group at the county level. But on the health services side or the health economic side, there's really nothing that's comparable. And so our goal was to say, hey, can we advance this space and try to measure healthcare spending and healthcare utilization at that same level, at the county level, and eventually by race and ethnicity as well.
So that's fantastic because it helps us all ground in on something right at county. We can grab that county and start to understand a heck of a lot about it. So my understanding is by looking at that variation across conditions and areas, we can start to learn something about what we might do about it. But again, you all had to put in a tremendous amount of work to bring these data together. So can you tell us a little bit about the types of data that you brought together for the project?
Yeah, we've been collecting data for about 4 years now and processing that data over a long time period. We focused initially on claims data. So we have about 40 billion insurance claims that we use for this study, and that includes Medicaid claims, Medicare claims, and also a lot of private insurance claims. And then we also have information on hospital administrative records, like admissions specifically, and also survey data to capture the uninsured, which of course don't show up in insurance claims. And it really is a big data synthesis problem of taking these different types of data, very big data in size, and putting them together to tell a story.
And so when you did put all those data together, tell us a little bit about what you found. Start with the basics. What were the conditions and settings that you were looking about, and what did you find?
Yeah, so we look at health conditions at two levels. There's the bigger category level and then the more granular specific health condition. So at the aggregated level, there's really 4 big categories, whereas most of the healthcare spending that we track. That's cardiovascular diseases, cancers, musculoskeletal disorders, and diabetes and kidney diseases. And together, that's almost $1 trillion. And so that's more, just to put that in perspective, than the U.S. spends on public education K through 12, and really an enormous amount of resources. At the more granular level, we spend the most on diabetes type 2, and that's about $144 billion in 2019. The second one is other musculoskeletal disorders, kind of a funny name, but that includes a hodgepodge of musculoskeletal disorders that don't fit elsewhere, things like joint pain or osteoporosis. That's $109 billion. Next is oral disorders. That includes just taking care of cavities and orthodontia. That's $93 billion. And finally is ischemic heart disease at $85 billion. And really, each one of these tells a different story about increases in spending over time, or who are the patients, what age groups, what sexes. And really, there's a lot that goes into understanding each one of these health conditions.
And so when you looked at those health conditions, can you talk about the variation that you found? Are counties mostly the same, pretty different? What did you find taking this out to the national level and then down to the county level?
We knew going into this study that across U.S. states, there's a lot of variation. There's states like Idaho that spend very little on healthcare relative to states like Alaska, New York, Massachusetts, which spend a lot per capita. We found that there's even more variation when you measure at the county level. And There are counties in our study that we found that are spending less than $4,000 per person per year on healthcare. Some of those are in Texas, Idaho, Utah as well. And then there are counties that are spending almost $13,000 per person. So there's this fourfold span between the counties that are spending the least on healthcare and the counties that are spending the most on healthcare. What's really interesting about that variation is that while it is immense, it's different depending on the type of care or the payer that you're looking at. So one of the things that we found is that across counties, there's more variation in out-of-pocket spending. So the amount that someone spends when they're at the doctor themselves, that could be co-pays or deductibles, or in the case of some of our oral disorders, spending on, straight out of pocket, as well as a lot of variation on emergency department spending. So some counties utilize emergency department care substantially more than other counties where more of the spending would be on outpatient ambulatory care. The last thing that we found is that there was a lot of variation in utilization rates. In fact, that was the thing that explains the biggest amount of variation across the counties. And what I mean by that is that it's factors about how often people are going to the doctor for a visit or an admission or filling a prescription that explains this huge difference in spending amounts.
I'd like to pick up on that last point. So differences in utilization, what does that tell us? Is there a right level of utilization? Is the lowest the best, or is the highest the best? Tell me more about what that means when you're looking at that enormous degree of variation between different counties.
First off, I think this is a little bit surprising and pretty interesting. So a lot of the conversation in health economics and health services is about prices. And we know that prices going up is one of the reasons we spend so much more each year relative to the year before. We know high prices is what differentiates the US from some other healthcare systems. But the fact that it's utilization explains the variation across counties is a really new and interesting observation here. And I think it tells us two things. One is it tells us about cost containment and starts to pose the question, are there places where we're using resources too much and that those could be limited? And it also tells us a little bit about access and equity. The idea would be, are there places that really need to be receiving more spending or more resources than actually have access to? So there's two different ways that you can approach this. And I think more than anything, it begs more analysis and more attention to this new data set that can explore these questions.
Yeah, and you did a little bit of a deeper dive in the other piece that we talked about, the concurrent publication JAMA Health Forum as well. Can you tell us a little bit about the deeper dive that you take in that manuscript?
Yeah, so that manuscript, that research study, essentially took the data set that we're discussing here and analyzed it in a wide variety of ways. It used different econometric methods to break out what are these key drivers. And one of the things we did was just re-ask this question about utilization versus prices versus the age and sex or the disease prevalence of a county, and came to this really stark conclusion that 67% of the variation that we see across counties is about utilization. And then we started to look at some correlates. What are the things that are most associated with the counties that are spending the most or utilizing services the most? And we found things like insurance rate, income, education, and also the fraction of the people on private insurance were all associated with more utilization.
Yeah, it's so interesting that there really is probably a Goldilocks here, right? Where people have enough access to use what they need, but maybe aren't overusing stuff that we know to be ultimately low value or harmful. And I think it's going to be really exciting to see where people can take this. Where should people take it? When people read this, either clinical leaders or policymakers, what are your big takeaways that you'd like people to leave with?
For me, I think there's a couple of really interesting takeaways. The first is that the most variation, even though we see variation everywhere, the most variation is out-of-pocket spending and emergency department use. And this is, in many ways, resources that in many cases could be prevented or could be treated elsewhere in some cases. And so that to me is an important takeaway, is that in some places a lot of money is coming out of pocket and a lot of spending is happening in the emergency department. And asking the question, what can be done in those places to either help the patients out that are doing the spending and make sure that they have access to the insurance they need, and that they have access to the preventative and primary care that they need that could maybe reduce some of that extra emergency department visits. So that's kind of one interesting takeaway. I think the other is exactly what you're saying about Goldilocks and trying to find the space in between where there is enormous amount of spending and where there is very little spending, and asking, are there places that are doing it right? Are there places where the outcomes are optimal relative to the spending and the inputs as well? And I think that's future analysis that we're really excited to be able to dive into.
Yeah, there's just so much we can learn from this kind of work. I know you've also been really focused on making these data usable and available and interpretable with visualizations. Can you talk about what that means for other folks who might be interested in diving into this type of work?
Yeah, so we want to see the output really be a public good. We want other researchers to use it. We want people to use it for a wide variety of reasons, for their own advocacy or for just understanding the healthcare system. So we're trying to make it as easy to access as possible. Now, to be clear, there's about 5 billion estimates that are made in this study. So it is big data and it's hard to work with, but we've done our best to make it accessible. Two ways that we've done that is one, an interactive visualization on our website. So if you go to healthdata.org, that's the Institute for Health Metrics and Evaluation. And within that, you can kind of find this new interactive that allows you to zoom in on states and counties and specific diseases and health conditions and understand the spending and utilization patterns. The other is the data is all available for download. And you can go to that same website to download the data. And that would be especially for other researchers that want to explore time trends or variation in these outcomes.
I haven't been bold enough to try to download the billions of pieces of data yet, but I have looked at the website, and I will say it is very neat to be able to look on there and to just see some of the patterns that you're talking about and sort of interact with it around the conditions that you're most interested in. To go in there and look at it is really neat, and hopefully will lead to, like you said, some nuance around how people think about spending and really being able to unpack this further. So also wanted to give you a chance to give a shout out to your team. I know it's an immense team that it takes to put this sort of thing together.
Yeah, there's a lot of co-authors on this paper, and that's because a lot of people put a lot of time and energy into it. So huge thanks to the team. Some people have been working on this for 4 years. It's really exciting to see it come out, and certainly wouldn't be possible without their dedication and hard work.
Well, thanks to you. Thanks to your whole team. This is such important work, and your efforts to make the data broadly available, I think even just go on to expand that impact over time. I'm Dr. Karen Joynt Maddox, and I've been speaking with Dr. Joe Dieleman about his work on county-level variation in healthcare spending. You can find a link to both articles in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.